Today we're going to review the Osteoboost device from Bone Health Technologies. So I've actually done a previous video on this topic, and in that video I was pretty critical of the device. The CEO of the company, Bone Health Technologies, actually reached out to me and requested that I meet with her and her chief medical officer and her team to talk about my concerns that I had with the previous publication. So there's an abstract that's been published. And I had some questions about the abstract and I wanted to see additional data. And so they wanted to meet, review the data, and present to me the write-up that has been accepted for publication. So we did that, and I had a fantastic conversation with them, and I have a good understanding of the product and their intent. And so I want to review that now. I'm going to go into depth on the study that is going to be published, and I want to talk about this technology. I'm going to talk about how it compares to whole body vibration. I'm going to talk about how it compares to other modalities for improving bone health and where I think this really fits in, because I do feel like there's a role for this product, and it's probably a big role. So stick around. I'm going to go through all these details and you can decide if this is something that's right for you. Okay, so this device again is like, it looks like a fanny pack, right? And it is a vibration device. It's FDA approved, and it generates vibration that is similar to like the Juvent and the Meradyne plates, which has a displacement of 0.1 to 0.3 millimeters of displacement, and it does that displacement at between 20 and 40 hertz. That's the frequency of the device. So it's kind of like a little vibration plate, right? It has force sensors in the front at the iliac crest, which is in the front of your hip, the points of your hip bone that stick out there. And the force sensors will actually increase or decrease what the vibration device is doing so that it can hit certain criteria. Now, they want you to wear this device for 30 minutes a day, and the goal is 5 days a week. Now, in the study, they actually had an app that went along with the device. I don't know if that'll actually be a part of the real world device, but they had an app that went along with the device where they were showing how often they used it, which is helpful to understand compliance. So now this device is, like I said, similar to the Meradyne or Juvent whole body vibration plate. So the smaller size platforms that you stand on and they move up and down. Now, I've done videos on this topic before, and I've actually done at least 4 that I can think of. The most recent one is the one that you should watch if you want to go back and look at that. And the reason why I did 3 is that I interviewed Clinton Rubin from Meradyne. I interviewed one of the PhDs from that was associated with PowerPlate, and then I did a summary video in the end. And in the end, what I decided based off of the research, which is really confusing, by the way, the research is challenging because there are studies that support that Meradyne is the best tool, but then when you look at the data, I can't imagine how they came up with that conclusion. And then when you look at other studies, you can see that you have to have a certain amount of displacement, which is more than Meradyne and Juvent. You have to generate enough acceleration to actually see the impact, literally impact running through your body to impact the spine and to impact the hips. And so from my perspective, the literature does not support the idea that Meradyne, if you're standing on it, will have an impact on the hips and the spine, not like a power plate will. So when we make a recommendation for a whole body vibration plate, we're saying we need a device that has 2 to 3 millimeters of displacement that moves in a 3D vertical pattern, and that device is a power plate. Power plate is the only device, and those are the only metrics that are going to show an increase in bone mineral density. But I will say that the Meradyne literature does show that at the local level, if you look at the CTs of the lower leg bone, from somebody who has been standing on the device for a year, you do see an improvement in bone. Okay, cool. So then maybe from a local perspective, this actually works. So then what they sought to do in this study was to take a device that could be applied locally to the spine, which would be more like the Meradyne device, that 0.1 to 0.3 millimeters of displacement, and then see if it would actually improve bone locally at the level of the spine, since you can wear it there. So this is actually kind of a cool study, and it's kind of a cool device. Now, what would happen if you put a power plate-like device directly on your spine? Well, it probably wouldn't feel very good, right? It's too much displacement. That's why we stand on it. So I think this is an interesting design and maybe a good way to take this device, the Meradyne-like device, and put it somewhere where it's actually going to have a benefit. Because to say this more clearly, I don't think that anybody standing on a Meradyne device or a Juvent device is going to see an increase in bone mineral density. There's just not enough displacement. There's not enough acceleration. So I think if you want that type of thing, a whole body vibration plate, you need something that has, again, 2 to 3 millimeters of displacement. Okay, so let's go through this manuscript. So this has not been published yet, so I'm not going to talk about all the details, but I can talk about it enough so we can get this point across. And I wanted to deliver this before it was published because a lot of people that are looking at buying this thing, and I wanted to get some recommendations out there. So this is a placebo-controlled, well, it's a sham-controlled trial. Everybody was on vitamin D and calcium. And what's cool is they actually looked at how much they were taking. So they were giving them a relatively accurate, hopefully, dose of calcium and vitamin D. So then there was a group that was in the sham group and then a group that was in the active group. The sham device actually made clicking noise. So, I was thinking, I'm like, how do you have a placebo group or a sham group? Because they're going to know that it's not vibrating. Well, remember the Meradyne, you don't feel a lot actually. But I think you are going to feel it. So for the sham device, they made the device click rather than vibrate. And so for people that had never felt the vibration, they felt like it was doing something. So that's actually pretty smart. So then when I look at manuscripts, I haven't done a full review in a while, but when I look at manuscripts, one of the first things I do is to look at the authors. Let's look at the authors. Where are they from? Where was this study done? And are there any conflicts of interest? And this is, of course, an industry-funded study. So there's going to be a conflict of interest, and this is not wrong by any means. This is how these studies are going to be done because nobody's going to fund them to do them. They're expensive to do. So this has to be an industry-funded study. But I'm just going to mention it here because I think it's relevant to know that most of the authors are either employed by Bone Health Technologies or have received research support or have been given stock options. So does that mean that they're biased and they're going to lie and show that this thing works when it doesn't? No, not necessarily. I would hope not. But it does open up the conversation about doing a follow-up study or trying to find someone who will seek funding to do a follow-up study on a device like this. I don't think it's needed, but I always like to point out bias when I see its potential there. Okay, so again, study design, single site. It was actually considered a triple-blinded randomized controlled trial that ran from August 2019 to June 2022. It's all very, very recent. The inclusion criteria, meaning the people in the study were postmenopausal women, aged greater than 50 years old with osteopenia. So it's kind of interesting, right? So this is really going to be used for people with osteoporosis, but the indications were for osteopenia, and there's some, I'm sure, the reasons why they chose to do that. Exclusion criteria included osteoporosis, treatment for osteoporosis, hormone replacement therapy, history of herniated discs, spinal fusion surgery, joint replacement, or people were already doing some kind of consistent engagement with high impact activity. And so I think that would have just confused the data. So I'm okay with all of that. I think that we can extrapolate for people that have osteopenia, what it's going to do with osteoporosis. The question is it going to be better or worse? And that would be, again, another reason to do another study with an osteoporotic population rather than osteopenic population. But I think, again, we can extrapolate those things. So the primary endpoint here is important. And what I mean by primary endpoint is what's the thing that they were looking at primarily? And then there were secondary endpoints too. So the primary endpoint was vertebral strength on biomechanical CT or BCT. Secondary endpoints included DEXA and then some other CT measurements, which we'll talk about. So remember that when we're talking about the outcomes here, we're talking about outcomes on CT. So why is that important? Well, most people aren't using CT to diagnose osteoporosis or even to follow treatment because CT is more expensive, there's more radiation, it's just not practical to do on a regular basis. They did it here because it is more sensitive than is DEXA. And I think all of my audience knows that DEXA has weaknesses. And if you're looking for what could be a narrow improvement, DEXA is not necessarily going to show it, right? And so CT is a better tool for this. So I think this is the tool that you should use in this study to understand how significant is the impact of this device. So biomechanical CT is actually a cool way to look at bone strength and to predict fracture risk. And so if we could get CTs that didn't have radiation and didn't cost anything, then this would be a great way to follow improvement in bone health programs. But again, that's not very realistic. Okay, so some of the challenge of biomechanical CT is that it's a relatively new technology. And they actually talk about this in the manuscript where understanding the clinical effectiveness is a little bit difficult because yes, we can make a statistically significant change, but what does that actually mean clinically? What is the reduction in fracture risk? That's a little bit hard to determine at this point. We'll get more data as more and more studies use this. Hey, sorry to pause this review of the Osteoboost, but if you are struggling to figure out what is the right thing for you, what your program should look like, and you have questions, why don't you come to our free masterclass? The masterclass we run about every 2 weeks. I do it personally. We talk about the common myths and misconceptions that we see over and over and over again in the people that are coming into our bone health practice. So we'll go through those, and then we leave about 20 minutes for Q&A. So if you haven't done that yet, go down to the description on YouTube and sign up for the masterclass. So they reported the data in 3 different groups, actually 4 different groups. So one would be an intent to treat analysis. The other is what's called a completer group, and then there's a per protocol group. And then in the completer group, they broke it down by age between 50 and 60, and then over 60. So of the 164 enrolled, there was a substantial amount of, not necessarily dropout, but people who didn't use it enough, and we'll talk about that. But let's talk about the results first, because these are really interesting. So with this primary endpoint of bone strength on biomechanical CT, in the active group, and this is on, again, the spine. In the active group, the people that had the actual vibration device, there was a loss of bone of negative 1.4%. Now, the sham group lost bone at negative 2.74%. Now, this was technically not significant, but this is the intent to treat group. Important points here is that both groups lost bone. One group just lost more, and it was the sham group that lost more, but it wasn't statistically significant, which doesn't mean that it's not clinically relevant. It just means that the study wasn't big enough to show it. Now, the per protocol group is really interesting. And this is the group of people that use the device at least 3 days a week for 30 minutes. Now, actually, if you look at the data, they used it on average 4.8. So they were very close to being compliant, but that was only 73 people. And that includes both sham and active. So only 73 out of the 164 actually made it into this group, meaning that others didn't use it enough. But if you look at this subgroup, which was predefined, so this wasn't a subgroup analysis that was inappropriate statistically, but this predefined subgroup, you could see that the active group still lost a little bit of bone at negative 0.48%, but the sham group lost negative 2.84%. So that's that 2.4% improvement in bone strength. And that is true. So this is a significant finding, both statistically and probably clinically. And then there's the completer group. And the completer group are people that just simply made it to the end, but they weren't necessarily in the per protocol group. But they made it to the end of the study, and we then can divide this up by age. So age 50 to 60, and then age over 60. And what you found in this 50 to 60 group is a loss of 1.5% in the active group and a loss of negative 3.4% in the sham group. And it was similar in the over 60, but a little bit less. So again, it's going to show people who didn't do it per protocol. And so probably not as relevant, but it's a bigger number and divided up by age. But you can see that that big gap, that 1.9% in the 50 to 60 group is another big number that's very relevant. Now, other measures on CT also improved. So volumetric bone mineral density improved, especially in the per protocol group. Improved vertebral bending stiffness was also seen on CT. But now let's get to the DEXA, because we're mostly using DEXA clinically, or REMS if people have access to it. So what did this do to DEXA? And this is one of the things I wanted to know because the abstract didn't mention it. I think it did mention that they used it, but there was no data. So I wanted to see the data. So here it is. So in the intent to treat group, the spine lost negative 0.32 bone mineral density, and the active group gained 0.42. So some narrow gap between the two of almost 0.75%, which is obviously within the margin of error on DEXA. So not statistically significant, probably not clinically relevant. In the hip, both groups, again, lost, but the difference between the two was almost like 0.5%. So if you look at the completer group, there was actually a small increase in bone mineral density in the spine, but not in the hip. And then if you look at the per protocol group, there was an increase in the spine, but there was also an increase in the spine in the control group, a little bit more in the active group. So challenging DEXA data because it isn't probably powerful enough to see through the noise on DEXA, but you can clearly see that there's a trend. The active group was always better. It just wasn't better by a lot. So my takeaways from the DEXA numbers are essentially that, okay, they're probably losing less bone on DEXA, but we're going to have to go with the CT data, and we're going to have to decide how clinically relevant that is, because the DEXA numbers are certainly all within the margin of error. It's not powerful enough to see through the noise of that study. So let's talk about some of the challenges of this device. So if you look at the per protocol group, again, there were only 73 people that actually used this almost 5 days per week for a year. 73 out of 164 is less than 50%. So if this is a device that was given to these participants and they decided not to use it, the question is why? Was it just boring? Did it hurt? Like, were there issues they tracked? And there aren't many, and I'll talk about them. So then what about tolerant? Were they able to tolerate it? And if this device is not tolerable, in other words, if you can't wear it, there's too much vibration. I could imagine like strapping my power plate to my spine, what that would do. It would be uncomfortable, but this is a small amount of vibration and it was well tolerated. So there were 5 participants that complained of back pain. 4 of them said that it got better when they stopped using the device, and then 1 continued to have back pain after stopping to use the device. But remember, in a population of older individuals, back pain is very, very common. So did this device cause the back pain? Hard to know. If somebody has a lot of low back pain, might this not be the right device? Maybe. I think we probably need a little bit more clinical data to know who is not going to have a good experience. Not contraindicated, but who's not going to have a good experience. So then in the end, what do we think about this device? Well, the vertebral strength benefit of 2.36% in the per protocol group is compelling, right? So I'm not as worried about the intent to treat group. I'm not as worried even about the completer group and the difference in the ages. I want to know about the people that actually used the device. And a change of 2.36% is pretty big. If we're going to offer this device to people and they're going to use it for years, I'm not even that worried that it didn't have a huge impact in 12 months, because ultimately, even though they're not building bone, it's slowing down bone loss without any other intervention. That's a huge win. Because remember, for most people, most patients, they're going to go to their doctor. They're going to want the quick fix. And this is just true. As a doctor, I can say this. Probably not most of my audience, but most people that go to the doctor want a quick fix. They want a surgery, they want a pill. This is the system that has created the patient that has these expectations. If this is a device that they're willing to wear, even if half of them are willing to wear it, and it slows down bone loss, and they're not willing to do anything else, that is a win. So I think there's definitely a role for this device. But who is it really right for? Well, so I'm a big fan of whole body vibration. So I like standing on my power plate. I like what it does for me. I use it first thing in the morning. I work out on it. It can improve balance and strength and bone density and detox pathways and flexibility and range of motion and recovery and on and on and on and on and on. I would not trade my power plate for the Osteoboost device. But not everybody can tolerate a power plate. Not everybody has access to a power plate. So then this is potentially a way to get the effect of whole body vibration locally at the level of the spine, probably more so than at the hip. So I do think this is an absolute win for those that are unable to tolerate more significant impact, those that are not able to do heel drops, those that are still losing bone despite doing all the other things that we talk about. If this is another thing that we can add to the mix, great. I think ultimately this is a risk-benefit analysis, just like every potential intervention, supplement, drug, surgery, whatever. This is a risk-benefit analysis. So the question is, what is the risk? And if there really isn't any risk, maybe if someone has pre-existing back pain, then they'd have to figure out if this is right for them. But aside from that, if there's no risk and there's only benefit and it's going to slow down bone loss or add to the other things that you're doing, this is still a win. Now, right now, this is only available through pre-order on their website. So if you go to osteoboost.com, you can click the pre-order button and you can fill out your information. You'll also need to get a prescription. So this company went through the rigor of getting FDA approval. They're getting this approved for hopefully coverage by commercial insurance and Medicare. So in the future, this might actually be a covered entity, and that would be a huge win for bone health, particularly in the older population. So again, if this is covered by insurance, there's very little risk. I have a hard time saying that this isn't a good idea for people. I mean, honestly, anybody, but definitely those that can't do all the other things. The question you have to ask yourself if you're going to invest in it now is, are you willing to do 30 minutes a day, 5 days a week? Because that appears to be the threshold. That 4.8 days per week was the threshold that the per protocol group actually had. So if you're interested in this device, go to osteoboost.com to pre-order and take the prescription form to your doctor to fill it out. It is by prescription only. I don't have any discount codes or affiliate codes for this device. They've gone through the rigor of getting it FDA approved, going through insurance. So this is not something that we can do the same thing like we would with a power plate or with a supplement. This is an FDA approved medical device. So we have to go down this very official pathway. But the good news is that they will be able to get this to a lot more people as a result of that. So I hope that all made sense. And remember that a diagnosis of osteoporosis isn't the end, but deciding to reverse it is the beginning. I'll see you in the next video.